morning, good evening, everyone. I am Dr. Shibu Vijayan from Qure.ai. I am the Medical Director of Global Health at Qure. Welcome to the Curiosity series. Today we have Dr. John P. May from Health Through Walls. He's the co-founder and president of Health Through Walls. Dr. May, we are excited to have you here for the Curiosity. We appreciate your good work being done through Health Through Walls, specifically focusing on health equity of the people who are in prisons. Could you please explain more about your work and about you and your work? How do you get into Health Through Walls? How do you kind of co-founded Health Through Walls as an organization? Over to you.
Sure. Thank you, Dr. It's a real pleasure for me to be here with you and share information about this work, because I think what Qure.ai and this technology is able to bring to prison health is very transformational. Health Through Walls is a non-governmental organization. I've been working in jails and prisons as a medical doctor for nearly 30 years now. I work full-time in the United States with a group called Centurion, and then we co-founded and am now president of Health Through Walls, which works around the world in prison settings to try to improve the health care for incarcerated persons. Our focus is primarily lower income countries where the needs are the greatest and we're able to make the biggest impact. So for more than 20 years, for example, we've been working in the prisons of Haiti, the poorest country in this hemisphere. But we're in multiple other countries too, including Dominican Republic and Jamaica, and throughout Africa. We're presently in Malawi, Central African Republic, and just starting in Mozambique. But we've had many good partners over the years and get many inquiries because more and more governments and groups are recognizing the enormous challenges and needs for taking care of people who are incarcerated around the world. Health Through Walls started as a volunteer organization, primarily doctors and nurses working in prisons in the United States who wanted to see how they could assist in other countries. And really, we have found an entire global community with this same commitment to improving the healthcare of prisoners. And so we work closely with groups around the world to try to find the best strategies, the best ways that we can leverage technology, resources, the limited workforces that are available to go inside prisons and meet the many needs of those who are there. Infectious disease is probably the largest issue that we are finding, and particularly in lower income countries. And so we've developed lots of models to try to impact infectious diseases such as HIV and hepatitis C, and of course, tuberculosis.
So thanks for that introduction. I haven't came across any organization which is completely exclusively focusing on health of prisons. You selected that as a mission for providing health for people who are in the prisons and also bringing the angle of health equity for the prisoners. How did you came to know that AI based an algorithm like a Qure.ai can help you in advancing or fast tracking your diagnosis? And what was your experience in working with technology?
It's always been recommended the best way for screening for tuberculosis is symptom screening. So you ask who's coughing, who's losing weight, who has night sweats. And so traditionally, most prisons around the world will ask those questions as people come into their facilities and screen them, or ask periodically. But when you have a largely overcrowded prison, as many are, in Haiti, for example, where we have the most experience, they're more than 400% overcapacity. So thousands of persons, mostly men, in facilities designed for much fewer than that. If you were to go through and ask, who's losing weight or who's having sweats at night, who's feeling sick, it's so challenging to develop an effective screening tool just with these basic tools. Over the years, as technology has become available, for example, the Gene Expert machine, right? And again, the guidelines has always been in low-income countries, we'll collect sputum and do acid-fast bacillus smear on a microscope. Again, very time-consuming, not so sensitive, very user-dependent, and to collect sputums from all these folks who have all of these symptoms and do this work, it takes a lot of time and effort, and you miss hundreds of people within your facility who may have disease. Identify drug resistance and develop treatment plans in a much more effective, useful way. Another technology, probably the most transformational for us to date, has been the use of digital X-ray screening. There we can identify active disease, of course, just with a chest X-ray. This is technology that have been used in wealthier countries for many years, particularly in the beginning of the HIV epidemic, when tuberculosis was coexistent so frequently there, and many jails in the United States, for example, started implementing digital X-ray screening of persons coming in through the front door. Again, lower income countries, this was not considered cost effective. The idea was, let's crowded spaces, it's within prisons. This is where, this is the place where we're going to find most tuberculosis in almost any country. So the digital X-ray, we can screen every person as they come through the door. We can identify active disease immediately. The next piece of this transformation is what you just mentioned, and that's then the use and introduction of artificial intelligence. Our process for the past 10 years in Haiti with the use of this digital X-ray machine, again, we were able to identify much more tuberculosis and save many lives than previously, because when this technology was not available, but it was dependent on a radiologist. And Haiti, for example, is a country that has just a handful of radiologists who are in high demand and not available. We worked with the medical schools to try to develop some launched learning programs there, but many challenges made that not successful at the time. So what we ended up doing was finding volunteer radiologists in other countries. We particularly had one here in Miami, Florida, who would read those X-rays. So we would have to email each film. So we have 200 X-rays a day. We would email those X-rays to the retired radiologist, who would, over the next few days, read each one, send back the reading. We would print them off. We would put them in a health record. We would locate the patient, who is now back into a different cell area, pull them out, hopefully, if it's suspicious, and start the evaluation and workup for tuberculosis. Frankly, you miss folks. Some persons in those few days may have been transferred to another facility, may have been released from the prison. Maybe there's some technical problems in getting the results back, or staff to follow up, and many opportunities for things. And the folks in Geneva, TB Reach, and that really were intrigued about the opportunity that we can apply this technology in prisons, particularly low-income prisons. And so for the past year or so, we've been able to do this now in Haiti in partnership with your organization. And we are able to, when we bring in the X-ray machine, we are able to get the results immediately, within minutes, while the patient is still there in the X-ray room, and make a determination whether they're good to go. They can return to their housing unit in their crowded space, or this is someone that we need to immediately isolate and begin a treatment care plan. So we don't have to depend on many days delay as getting these results, because we really invite efficiency, and we want to bring the very best care that we can to places where the burden of disease is the most.
Yeah. So nicely summarized it. So if I could kind of reflect back on what I heard. You brought in a lot of, actually, you're working in a very challenging condition wherein there is high burden and there is high transmission setting. And then you started with a very low sensitive tools, especially smear and then verbal screening. Then you brought in, like in a sequential manner, you brought in advances in technology, like digital X-ray came in first. You figured out something then gene expert came in, you figured out something. Still, your problem are not getting solved. By bringing in AI, you brought in a lot of efficiency, you fill the gap of skill set availability, and the turnaround time for diagnosis has significantly reduced. And by doing that, you also plugged in the leakages in the system of by identifying the patients. So this is so exciting to hear this story about like okay the how technology is coupled with the right mind and right mission is actually supporting patients. So could you please also explain that so far, how many X-rays has been scanned over the years, and then how much is your the number needed to screen, if you have that numbers handy?
I don't have the exact numbers. I can give you an approximation, but in Haiti this past year, and 2022, I tell you, was probably one of the harshest, most difficult years in Haiti. Active government for a year and a half. It's considered a high-risk travel country, so most of the international support has fled. Imagine it's almost the worst situation you could, and that's the scenario there. Then in prisons, which traditionally are not a priority for most governments and communities and so forth, you know, are thousands of persons who have needs. There are 12,000 people presently incarcerated in prisons throughout Haiti in about 17 different prisons. The main prison has nearly 4,000 persons in downtown Port-au-Prince. And so staff have to travel there each day. Despite that, our team in Health Through Walls was able to visit many of the prisons through the year and again bring in this digital x-ray equipment with the artificial intelligence and use that opportunity when they finally get to the prison to conduct the blitz. And they often stay overnight at the prison or next door to reduce the travel impact and go through as many persons as possible. So in 2022, we were able to screen approximately 5,000 persons, and we found ultimately 10% with active disease. So more than 500 cases of active tuberculosis disease, which is extraordinarily high. And again, these are all patients who would then potentially expose others, staff and other incarcerated persons. So the initiative is very important. Of those 5,000 screened, maybe about 12% or so had abnormal results with the Qure.ai technology, and of those abnormals, about 80% of those abnormals turned out to be confirmed with active disease through the gene expert and the other confirmation tests or even clinical approaches that we use to then put somebody on treatment, which can cure them.
So this is interesting. So just a bit out of curiosity, because 80% of the X-ray positives becoming microbiologically diagnosed, or is it a mix of microbiological and clinical, right?
It's the protocol in Haiti, for example, really depends on bacteriologically confirmed. 90% plus are confirmed bacteriologically. Of those 80% that have the tuberculosis suspect based on the Qure.ai. Perhaps there's even more sensitivity in the AI algorithm identifying disease than a human radiologist. We haven't evaluated that correctly, but I think more likely it's that.
Yeah, I think it's good to look at from an academic standpoint also, what are purely academic, like after X-ray AI saying that these are probables is slightly on the higher side, because what we typically see around 30 to 40% positivity among the X-ray being identified.
Well, again, those were of the positive that were suspicious for tuberculosis. Not, there are many other lung findings that the technology can provide to us.
I mean, I'm just saying from an AA standpoint, we have capability of offering multiple lung findings, right?
Yes.
So, I mean, given that you have the technology access now, are you thinking about offering a comprehensive lung health based on what finding coming out?
It's something we certainly will want to look at more in the future. we're trying our best to catch up with the big burden we have now.
I mean, I get it. So I also understand these are all high HIV setting also, because most of the, places like, what proportion of the TB patients are HIV positive? Probably around 30-40% of your current patients will be HIV positive also. So how do you do this? What is the workflow you
I've been
follow?
describing the model mostly in Haiti, but as I mentioned, we work in multiple countries, so each country may have a different protocol. But our ideal approach, and the one that we're presently using in Haiti, is two-pronged. There's an entrance exam. So when persons first come into the facility, they receive a medical screening. And at that point, we do HIV testing, and it's usually opt-out testing. The chest X-ray is performed at the same time, along with a health assessment, vital signs, and examination by a physician, and so forth. Then over the time while they are in custody, we have teams of peer educators, so other incarcerated persons who receive specialized training in health, and they are the watchers and the influencers throughout the facilities, and they will educate on things like HIV infection, like tuberculosis, like cholera, or other the threats, infectious disease threats that we see within prisons. It's usually these blitzes where once again we offer the HIV test along with the tuberculosis screening with the X-ray. We did evaluate it. One time we found that those incarcerated persons who had exposure to our peer educators were several times more likely to accept the screenings than others. So it's an important piece of the process of educating with peers on the importance of disease screening and access to treatment. As persons who are in often marginalized communities, higher risk activity, poor access to healthcare, missed opportunities for health equity, we can change that within the prisons. We can enhance health equity by bringing all the services that are often missed in the community, and education and prevention messages. So that's where we find HIV is often, when they first come in, many didn't know that they have it. It was this contact with the criminal justice system that educated them about their condition and got them into treatment. Tuberculosis is almost the opposite. We find few coming into the door with tuberculosis. We find it later on after they've been in for a while. And the interesting question is, how is that? Is it because they were exposed later on in these very overcrowded, cells, 80 persons in a room intended for 10 or 20, often with poor ventilation in their day and night? Or is it reactivation of latent disease, right? We have transmission of active disease to persons who have not previously been infected. But in many countries, there's a very high burden of latent disease in short supply. So there's a lot of malnutrition within the prisons. The stress level is extraordinarily high. The conditions are poor. It's really an opportunity for any latent infection to emerge into active disease. And so you may miss them when they first come in screening, but you need to identify it later on. And again, that's why, to go through who's coughing or who's losing weight, almost everyone will say something, but you can do that X-ray and get that immediate interpretation of the X-ray. You're going to find a lot of active disease.
So just, I know what is the periodicity you revisit one person? Like, is it 6 monthly or annually, one screening?
We like to do it at least once a year.
Okay, once a year.
At least once a year, yes.
And do you have data points of, what is the breakdown? You should be able to do it, right? Like you can maybe screen me this year and next year, probably like it will come up.
Yeah, again, all I can tell you is that most of the active cases that are found are persons who have been in prison for more than 1 year. They're not found when they first come in. That's just a handful of cases, probably 5% of all the after tuberculosis disease is when they're first coming into the facility. That would vary by country and what's going on, but particularly in Haiti, it's while the folks are incarcerated. And you were asking before about HIV. Certainly, those with HIV infection are more likely to have this. We focus on prevention as much as possible, and anyone with HIV infection is placed on isoniazid or other agents to prevent tuberculosis while they are in custody. But it's challenging.
Yeah. So that's a perfect setting actually for 3HP or short-term preventive treatment, because you can also monitor it, because you have a system, you have this influencers or quasi health workers within the. So I think that will benefit a lot in breaking down the infection to disease. Given that people are going through a stressful situation, then the disease might be breaking down. Infection might be breaking down to disease. Then, that setting, because it's a controlled setting, you can actually have, short duration, highly efficient.
Exactly. We're beginning to launch this program in Mozambique, in prisons of Mozambique, with this focus on preventive treatment. And so we're going to be doing the screening with the digital X-ray, artificial intelligence reading. We're going to identify the active disease, but then we're going to also look at latent disease and offer preventive treatment to the higher risk groups. This is with TV reach, and we're going to have some academic support behind it, so we'll be able to analyze, as you suggested, these findings, and I think we'll finally be able to prove this point. And to your other mention of 3HP, that again is another. I put it in the bucket of the technologies or the approaches that traditionally have not been welcomed for lower income countries, because this is an expensive regimen. It's more expensive than giving a pill each day of isoniazid. But the 3HP protocol, as you know, is just 12 doses once a week, these pills, and then you're done, and it cures it. Tougher too. Again, we would prefer to use an IGRA test, the blood test. That's going to be particularly in areas with a lot of immunodeficiency, with HIV or others.
So there is a new generation skin test which has been developed by Serum Institute, which is actually a Denmark research product from, and it's been transferred to Serum Institute in India. And I have good connects there. This is not of the Curiosity dialogue, but again, from out of interest. So I can negotiate with them if you have for a donation or a subsidized pricing. From a standpoint of maybe,
I'd be very interested in that. Yes, we're trying to find some solutions for this.
Product need to be registered and regulatory approval need to be there, and maybe a few cases we can negotiate for a lower price, and then it will be far more. It's going to be far more, cost effective than what IGRA offers. The advantage of that is that they have a self-injectable or not a auto-injectable device. They're using that. No worries. So so Dr. May, this is very interesting to actually listen to what you are thinking and what you're actually how you're approaching it. This is in a comprehensive way of offering periodic screening using technologies and offering, and also thinking about bringing in advancements in the infection prevention and preventive treatment for tuberculosis within the prisons. So I would want to actually hear from you before we conclude. How would you want to take this lesson to a scaled up initiative rather than projects?
Well, we are eager to see that happen, in part through mechanisms like we're doing here today, just sharing the good news, that this is a solution and an effective strategy. Qure.ai has worked with the International Corrections and Prison Association, and we work with the International Committee of the Red Cross and the World Health Organization and other groups to look at prisons a bit differently, recognize the unique needs and solutions that are required. and we'd like to see it expanded. I think, again, if Haiti can do it despite all the enormous challenges they have and limited resources, many other countries can take hold of this and really go with it. So I'd like to see it expanded, and we're available to assist folks in any way.
So these are all opportunities to bring in more evidence to the larger world. What you would want to convey to the larger world?
My first ask would be that folks recognize the importance of health of those in prison. I think they're too often neglected. It's not a priority for governments. It's not a priority for the medical community often, right? And advocacy groups. And yet these are persons, and the needs are overwhelming. Effective in eradicating or controlling infectious disease if, again, we don't focus on the prisons. These are often the hubs in many countries of these infections. So we need to put resources and attention to the health needs of those in prison. We can prove that it can be done efficiently and effectively and really make a difference in reducing disease and improving health.
We can
end TB.